Very good afternoon, everybody. I welcome you all to the CCR on behalf of Pediatrics. I'm Dr. Vandana Jain, and today our AIIMS will be presenting 3 cases to highlight that we need to sometimes think beyond type 1 when we see a child with diabetes. So, how we reach the diagnosis and how we manage those children, this will be the topic of today's CCR. So, I call upon Dr. Praveen first.
Good afternoon. So we've titled our presentation From Broad Strokes to Fine Lines, Precision Medicine's Impact on Childhood Diabetes. So as we all know, genetic diagnosis has sort of made a significant impact on the quality of care across medical specialties. So in this presentation, we would like to highlight 3 children with diabetes that we managed over the last 1 year, where the genetic diagnosis was able to give us more information and we were able to provide care beyond just glycemic control. So going on to the first patient, this was a 6-month-old baby girl who presented to us with history of fever for 7 days, loose stools, vomiting and fast breathing for 1 day. So for this febrile illness, the baby was admitted at a private hospital where for about a day, where she was noted to have a hemoglobin of 2.1, which was a macrocytic anemia, and she received a Paxil transfusion during the admission. But over the 24 hours that she was admitted over there, she had a significant worsening of her clinical status, and so she was referred to our institution. She otherwise had an uncomplicated antenatal period. She was a developmentally normal child. There was history of some poor weight gain, which the parents had noticed. However, there was no previous hospital admission or any illness, and there was no family history of any blood transfusion. She was a product of a 3rd-degree consanguineous marriage. She had an elder sibling who was well, and there was no family history of diabetes or any family history of transfusion. So on examination in the emergency, the baby was tachycardic, she was hypotensive, she was tachypneic. On examination of the anthropometry, there was failure to thrive. Her weight was 5.5 kgs, which was minus 3 SD. And on examination, she had a depressed anterior fontanelle with dry oral mucosa and delayed skin pinch to suggest that she was severely dehydrated. She had Kussmaul's breathing to suggest acidosis, and her systemic examination was unremarkable. Going into the investigations that were performed in the emergency, her blood glucose was noted to be high at 765 milligram per deciliter. Her blood ketones was large and her bicarbonate was low, suggesting the diagnosis of a severe diabetic ketoacidosis. So owing to the hemodynamic compromised state that she presented in, she received a fluid bolus, after which she was started on intravenous fluids and insulin as per the ISPAT guidelines. So this child actually took nearly 54 hours for the resolution of the acidosis. And going on to the possibilities that we considered in the 6-month-old infant who presented with severe diabetic ketoacidosis, as with any child presenting with a diabetic ketoacidosis, we need to consider type 1 diabetes. Considering the age of presentation, neonatal diabetes and other monogenic forms of diabetes need to be considered. Considering she had diabetes with macrocytic anemia, the possibility of a thiamine-responsive megaloblastic anemia needed to be considered. However, there was no history of hearing loss. However, we need to also consider that the baby was only 6 months old. And in any infant presenting with metabolic acidosis, ketosis, and hyperglycemia, after a short febrile illness, the possibility of organic acidemia also needs to be considered. So, as the child came in very sick, besides insulin, we also covered for the other differentials that we considered. So, the baby was started on high dose of thiamine and on a metabolic cocktail to cover for the metabolic disorder that we suspected. So interestingly, after initiation of these medications, the baby was discontinued of insulin on day 5 of presentation as the blood sugars were normal. Going into the further evaluation, the GAD antibody was negative, thus ruling out type 1 diabetes. Her thyroid function status was normal. Her urine GCMS and the blood TMS was normal, thus making the possibility of a metabolic disorder unlikely. We went ahead with a BERA test, which showed bilateral severe to profound hearing loss. And then we went ahead with the molecular testing for monogenic diabetes, which showed a pathogenic homozygous mutation in exon 4 of SLC19A2, which results in thiamine-responsive megaloblastic anemia. The components of which are diabetes mellitus, megaloblastic anemia, and bilateral sensory neural hearing loss, all three of which was present in our infant. So the blood glucose in the ward was normal after initiation of thiamine. She was discharged off insulin on oral thiamine. So this was the baby at discharge. She looked well at discharge. And 3 months later, when we followed up the baby in the clinic, the parents had actually discontinued thiamine for a month. And they had noticed some polyuria over the last 1 week before coming to the clinic. Her RBS was 201 in the OPD, and she was given 1 unit of glargine, which is a long-acting analog insulin, and she was restarted on oral thiamine. She was admitted in the ward for glucose monitoring and for the titration of insulin, but we realized once again that restarting thiamine resulted in normal blood sugars, and she actually did not require any further insulin. So the baby was again discharged on thiamine, compliance to treatment was emphasized, and a close follow-up is being planned. So as you can see in this diagram, this is the beta cell where glucose enters the cell through the glucose transporter. It then takes part in glycolysis, and then through the Krebs cycle, there is production of ATP. The ATP is then utilized by the ATP-sensitive potassium channel, where the potassium moves out, resulting in a depolarization of the membrane. This causes an influx in the calcium and insulin to be secreted. Now, as we all know, thiamine is actually needed as a cofactor in many steps of the Krebs cycle. So there are 2 thiamine transporters, the THTR1, which is coded by SLC19A2, and THTR2, which is coded by SLC19A3. Now, the THTR2 receptor is actually expressed by almost all organs in the body, whereas what is exclusive about the pancreatic beta cell, the erythrocyte, and the cochlea is that it expresses only THTR1 as a transporter. So when we have a defect in SLC19A2, as seen in our child, there is a defect in thiamine entering into the cell and taking part in the Krebs cycle and leading to manifestations of the thiamine deficiency. So the treatment for this is by giving high dose of thiamine, which actually diffuses through the leads to a passive passage through the transporter, and the effects of thiamine deficiency being mitigated. So the learning points that we had from this particular child is the importance of establishing a definitive diagnosis in neonatal diabetes, especially when there are some other clinical clues such as macrocytic anemia and hearing loss in our baby. And early treatment with thiamine in thiamine-responsive megaloblastic anemia actually prevents permanent diabetes mellitus. So the earlier you start thiamine, the less likelihood of permanent diabetes. Some of these children will still need insulin later when the requirement goes up, as in puberty. And antenatal counseling can be offered when we have a very specific diagnosis. As you may have noticed in our family, it was a consanguineous marriage. And definitely we can anticipate this in the next pregnancy, considering it's an autosomal recessive disorder. So with that, we come to the end of the first case. I'll hand over to Dr. Sukanya for the second case.
So we move to the second case. This is the case of a 14.5-year-old girl who presented outside with a complaint of pain. On evaluation, she was found to have glycosuria, and on further evaluation, she was incidentally diagnosed to have diabetes mellitus. A provisional diagnosis of type 1 diabetes was made, and she was started on subcutaneous insulin using the mixed split regime at a dose of 1 unit per kg per day. 2 months into her illness, she presented to our emergency room with abnormal body movements of the semiology of generalized tonic-clonic seizures with impaired awareness and low glucose of 40 milligrams per deciliter at the time. She was treated with intravenous dextrose and was administered a loading dose of an IV anti-seizure medication. We took relevant history and found that there was no history of skipping of meals, fever, or any extra exogenous insulin administration. When we delved into the history around the time of onset of diabetes, we found that she did not have osmotic symptoms either, in that there was no history of polyuria, polydipsia, or polyphagia prior to the diagnosis of diabetes. Looking
at her family history, we see that she has an affected mother who was diagnosed with diabetes at the age of 30 years in view of non-resolving skin infection. And at the time, she was being managed on 5 different anti-diabetic agents. There was also a suspicious history of diabetes in the maternal grandfather, who had a history of prolonged polyuria and eventually died of renal disease at the age of 45 years. Unfortunately, he could never be evaluated for diabetes. So when we examined our index patient, we found that there were no features of insulin resistance, overweight, or obesity, and there were no features of autoimmunity in this child. We admitted this child, we switched her to a more physiological basal bolus regime of insulin treatment, reduced its total daily dose to a much lower 0.25 units per kg per day, and educated both the child and her parents regarding the identification and appropriate management of hypoglycemia. Our initial impression was still type 1 diabetes mellitus in the honeymoon phase requiring a very low dose of insulin, but there were certain pointers which actually led us to consider other forms of diabetes such as type 2 diabetes as well as maturity onset diabetes of the young. So particularly the age at onset in adolescence, absence of osmotic symptoms, that is polyuria and polydipsia at onset, absence of diabetic ketoacidosis at onset, a strong family history, a lean phenotype, and absence of features of insulin resistance on examination led us to consider the possibility of a monogenic form of diabetes very strongly. Further investigations confirmed the findings of absence of autoimmunity and any feature of metabolic syndrome. So we went ahead with molecular genetic testing, which revealed the presence of a likely pathogenic heterozygous splice-site variant in this gene called HNF4A. This gene, HNF4A, encodes a hepatocyte nuclear transcription factor 4 alpha, which is crucial for insulin synthesis by beta cells of Langerhans. When this gene is defective, it results in a reduction in insulin synthesis and secretion and eventual development of diabetes mellitus. This disease is autosomal dominant in its inheritance, which is why a segregation analysis was done and the same variant was identified in the diabetic mother of this child. Majority of the diabetes of the young, including HNF4A variation, is amenable to treatment with oral anti-diabetic agents such as sulfonylurea, meglitinides, and dipeptidase 4 inhibitors, which is why we transitioned our index patient from insulin that she was receiving earlier to sulfonylurea, which was glibenclamide in her case. Because of the autosomal dominant nature of inheritance of this disease, we screened other family members for diabetes and found that the maternal grandmother and the father of the index case did not have diabetes. However, the elder sibling, who was 23 years old at the time, was incidentally diagnosed to have diabetes at the time of screening with an HbA1c of 10% and a fasting glucose of 250 milligrams per deciliter. So, as shown earlier, we had switched our index patient from insulin subcutaneous to oral glibenclamide at a low dose of 5 mg per day when she had achieved a better HbA1c of 8.6%. We started her elder sibling on upfront glibenclamide at a lower dose again of 5 mg per day. And in consultation with endocrinology department, we modified the medication regime of the mother such that she was later kept on 2 oral anti-diabetic medications, which were believed to best result in an efficacious improvement in the HbA1c. Through the follow-up of this child over the month, we noted that there was an improvement in HbA1c from the earlier 10.5% to 8.6% while she had been on subcutaneous insulin. But when we transitioned her to glibenclamide, there was actually a deterioration in her HbA1c values. The glycemic control had worsened such that the HbA1c had risen from 8.6% to 10.4%, even as she had continued to take glibenclamide at progressively higher doses to a near maximal dose of 17.5 mg per day. However, not surprisingly, the brother's HbA1c improved from the earlier 10% to the later 6.9%, even on a low dose of glibenclamide. And the mother, unfortunately, had again a worsening of her glycemic control with a worsening of HbA1c value from the earlier 5.7% to a later 7.6%. So this was a cause of concern for us with respect to why the index patient and the mother had not responded well to oral anti-diabetic therapy, even though the brother had beautifully responded to the same. While we were pondering around this, the index patient presented to our ER again with pain abdomen. This time she had an ultrasound report from outside which included the presence of renal calculi. We repeated imaging in-house to confirm or refute this finding. While renal calculi were not noted in the repeat imaging, there was something very interesting that we found out which eventually led to a change in her management. So to discuss this finding, I would like to call on Dr. Senior Resident from Radio Diagnosis to elaborate on the findings.
Thank you, Dr. Sukanya. So as you can see, this is the NCCT abdomen scar. In the yellow arrowhead is showing the head of the pancreas. So the head of the pancreas is shown, but in the region of the body and tail of the pancreas, we do not see any pancreatic tissue. So from our CT, the provisional diagnosis of a dorsal pancreatic agenesis or atrophy could be made. Now coming to the MR section. So these are the MR T1 and T2 axial section. As you can see, so the pancreatic head is well visualized in both the T1 and T2, but the pancreatic tail and the body region are actually not poorly are not visualized, and the pancreatic body and tail region is replaced by the bile. So the possibility could be a pancreatic agenesis or atrophy. Here even in the splenic hilum region, there is no evidence of any pancreatic tail region. So the possibility could be pancreatic atrophy or agenesis. So we have to go for a 3D MRCP to distinguish whether it's a pancreatic atrophy or agenesis. Here, as you can see in a 3D MRCP section, this is the ventral pancreatic duct body is seen, but there is no evidence of any main pancreatic duct or the dorsal pancreatic duct is not seen. So from these the finding, this is the CBD, this is the ventral pancreatic duct board. So my final diagnosis in this patient, it's a case of pancreatic dorsal agenesis. It's not atrophy, it's a pancreatic dorsal agenesis. Now coming to the mother's ultrasonogram. Here in the mother's ultrasonogram, in the limited ultrasound spots, we can see in the pancreatic head region there is echogenic tissue. So this is the pancreatic head, but in the pancreatic body and tail region we don't see any kind of pancreatic tissue. So it could be a case of dorsal pancreatic agenesis. So from the two cases both in the boy and the mother, so my primary diagnosis would be a dorsal pancreatic agenesis. Thank you. Now I will invite Dr. Sukanya for further discussion.
So we saw that there was agenesis of the dorsal portion of the pancreas in both the index case and her mother, and this finding was actually not seen in the elder sibling. Because of this finding, we thought that the insulin reserve might not be sufficient to sustain a sulfonylurea response, and we restarted the index case on basal insulin, although at a lower dose of 0.2 unit per kg per day. And this actually led to improvement of her self-monitored blood glucose record. We are yet to see her follow-up HbA1c values, but we feel that it's actually going to be much better. The mother is planned to be started on basal insulin, and the brother continues to be on oral sulfonylurea because of the excellent response that he had exhibited. So this was the slide that we had seen earlier, which showed how insulin is synthesized and secreted by beta cells of the islets of Langerhans of the pancreas. Inside the nucleus, we can see there are multiple transcription factors, including HNF4 alpha, which participate in insulin synthesis by the beta cells. And if any of these transcription factors is defective, it can actually result in a reduction in insulin synthesis and onset of maturity onset diabetes of the young. So there are many forms of MODY which we treat with oral anti-diabetic agents, particularly sulfonylurea. And the mechanism is such that they block these potassium channels, which are ATP-sensitive potassium channels, such that potassium is not able to move out of the cell. There is cellular depolarization, resulting in increased exocytosis of insulin from the granules inside which it is contained out into the circulation, resulting in increased insulin secretion. So it is important to remember that in a patient with MODY, particularly someone who has a defective HNF4 alpha or HNF1 alpha or any other transcription factors for that matter, many a times the demand for increased insulin secretion is not met when we are administering sulfonylurea. That results in increased abnormal transcriptional activity in the presence of these abnormal transcription factors, endoplasmic reticular stress, and eventual apoptosis of beta cells. So many of these patients, some of who are on sulfonylureas and some of who even may not be on sulfonylureas, eventually progress to progressive decline of beta cells, progressive beta cells loss, and that is why they may become insulin dependent over time. So while treatment with sulfonylurea seems very promising early on, it must be remembered that it is not a permanent treatment, and oftentimes many of these patients require insulin. And as was evident in our index patient, this was manifested much earlier owing to her dorsal pancreatic agenesis. So this slide shows a few other forms of maturity onset diabetes diabetes of the young, some of which, the first three of which are most common. And our index patient had the first type of MODY, which is due to a defect in insulin synthesis and which is amenable to treatment with oral anti-diabetic agents. And as we can see, many of these can be treated with oral agents, but some of these require insulin upfront for their treatment. And these are the ones in which we often get to see pancreatic hypoplasia or pancreatic agenesis, in which the insulin reserves are already exhausted. So the learning points from this case are that we need to keep a very high index of suspicion for MODY in an adolescent presenting with diabetes without a history of diabetic ketoacidosis or osmotic symptoms and a strong positive family history. We have the availability of targeted therapies which should be used. Because of the nature of inheritance of some of these forms of MODY, the family members must be screened and timely treatment initiated. But it must be remembered at the same time that despite oral treatment of MODY can be quite challenging, with eventual progression to insulin dependence, compounded by factors such as pancreatic morphology, as was highlighted by Dr. Prabhat, and pre-existing insulin resistance should there be any. So we quickly move on to our third and last case. This is that of a 1 year and 2 month old boy who was diagnosed with type 1 diabetes following an episode of severe diabetic ketoacidosis. He had a positive anti-GAD65 antibody, which was suggestive of type 1 diabetes mellitus. It was interesting to note that he had a very high insulin requirement right from the beginning at 2 units per kg per day. At 1 year and 10 months of age, he was also diagnosed to have primary hypothyroidism, which was secondary to autoimmune thyroiditis, which was also in keeping with the diagnosis of type 1 diabetes. His celiac serology was negative, a comorbidity that we often see in patients with type 1 diabetes. At 2.5 years of age, this boy now presented to our emergency room with compensated heart failure due to severe anemia. This was an unusual finding and could not be explained by the underlying diagnosis of this child. So when we examined and evaluated this child further, we noted that he was underweight, he had severe stunting, and there were certain findings on general physical examination that included facial dysmorphism in the form of coarse facies, hypertelorism, depressed nasal bridge, and bulbous nose tip, along with hyperpigmented indurated plaques over both of his lower limbs. So as can be seen in this picture, he has hyperpigmented areas over the thighs and the legs. These areas were also indurated and hypertrichotic, and there was characteristic sparing of knees of both lower limbs. Systemic examination revealed findings of distended abdomen and splenohepatomegaly, and investigations confirmed the presence of a severe microcytic hypochromic anemia likely due to iron deficiency and raised inflammatory markers in the form of an elevated CRP and ESR, which continued to remain elevated even after the acute illness of the child had settled. So when we did a database search, putting together the constellation of findings of hyperglycemia, hepatosplenomegaly, short stature, and hyperpigmentation, we came across an interesting syndrome called H syndrome. It is a monogenic disorder which is autosomal recessive in its inheritance, and it is also associated with findings such as microcytic hypochromic anemia, facial dysmorphism, and elevated inflammatory markers, all of which were also found in our index patient. So we went ahead with a molecular genetic testing which confirmed our suspicion and showed the presence of a likely compound heterozygous variation in SLC29A3 gene. Now before I discuss the management of this child that we undertook subsequently, I'd briefly like to touch upon the pathophysiology of H syndrome. So SLC29A3 gene encodes a transporter called HENT3, which is called human equilibrative nucleoside transporter. As the name suggests, it is responsible for transporting nucleosides across endolysosomal and mitochondrial membrane. And when this transporter is defective, there is a buildup of nucleoside debris in endolysosomes, and this nucleoside debris activates the inflammasome pathway via toll-like receptors 7 and 8, which in turn results in activation of the MAP kinase pathway and downstream pathways, which result in increased expression of pro-inflammatory cytokines and chemokines and decreased expression of anti-apoptotic proteins, resulting in proliferation of these histiocytes, resulting in histiocytosis. So it is speculated that pro-inflammatory milieu will result in insulin resistance and hyperglycemia, whereas this histiocytotic picture will result in infiltration of the islets of Langerhans of the pancreas and eventual development of diabetes. So in consultation with our pediatric rheumatology division, we did a literature review to determine what would be the optimal line of management for this index patient to be able to address some of his extra diabetic features such as skin manifestations and poor growth. There were multiple immunomodulatory agents which had been tried in these patients, the most common of which was methotrexate, and it was also probably the safest, which is why we went ahead with treatment with methotrexate. And after 9 months of treatment with this agent, we found a mild reduction in the hyperpigmentation, although it was not significant. Because of lack of response to this agent, it was decided by the division that we would go ahead and administer tocilizumab, a more potent and efficacious agent, which is an interleukin receptor 6 antagonist to this patient. So far, he has received only 3 doses of tocilizumab, but that has resulted in a marked improvement in the child's activity and alertness, with an interesting observation of a slight reduction in insulin requirement from the earlier high dosage of 2 units per kg per day to a recent dose of 1.7 units per kg per day. Now, this reduction is very slight at best and can be attributed to increased activity and alertness, but it would be interesting to follow this child up and see how he fares in the future and whether this insulin requirement comes down even further. So the learning points from this case are the importance of establishing a definitive diagnosis when diabetes is accompanied by multisystemic involvement, timely surveillance for associated comorbidities, and use of targeted therapies, some of which are aimed at treating the extra glycemic effects, but some of which may actually have the potential to optimize glycemic control as well. So summarizing the findings from all the 3 cases that we described just now, it is important to remember that not all childhood diabetes is type 1. A careful history and a careful examination will provide clues to specific etiologies. An accurate diagnosis has implications for offering precision therapies that optimize glycemic control but may also have extra glycemic effects. And an accurate diagnosis is also useful for screening other members of the family and antenatal counseling, as was highlighted in the previous cases. So with this, I would like to conclude and also thank the Department of Radiodiagnosis, the Division of Pediatric Rheumatology, and the Department of Endocrinology for their collaborative efforts. Thank you. And I'd like to call upon Professor Vandana Cherian for concluding remarks.
So the aim was just to highlight once again that whenever you see a child with diabetes with either unusual features or with a strong family history, because family history is not very common in children with type 1 diabetes, oftentimes it's the first child in the family to develop diabetes, or you have a very unusual age of presentation, so like very young age. We have earlier presented in this forum many cases of infants presenting as early as 1 week of age, 2 to 3 months of age, and they typically have monogenic diabetes. But this child, the first one that we presented, he presented at 6 months of age, so had very unusual features of very severe anemia, and then on further investigations was found to have profound hearing loss. So that is TRMA. TRMA, earlier we have seen a few children, but they were usually older. So in fact, one child is currently also admitted with us who was diagnosed at around 3 years of age. He actually was not free from insulin despite starting with thiamine, although the hematological parameters significantly improved. Again, with the H syndrome, we have seen children presenting at later ages. We currently have children who are like 19, 20 years of age. Some of them have also have additional H features, as we all know. They may have hypogonadism, hypertrichosis. They may have heart problems. So they sometimes have very significant joint issues. So in fact, Dr. Bagri is here. Dr. Bagri, would you like to add anything about H syndrome? And the house is also open to questions and comments.
Thank you for collecting these cases. And I think as far as H syndrome is concerned, and I was discussing with dermatology colleagues the other day, that they would first report to dermatology because skin is something which brings attention first rather than the visceral organ involvement. And that would be the case with most of these kids as well. But underlying pathogenesis, as Sukanya has highlighted here, the pathogenic mechanism is the autoinflammation or inflammatory cascade triggered by a host of cytokines. And here the predominant cytokine was IL-6, and we can see that after starting tocilizumab, there was, in addition to the overall activity, there was laboratory investigations wise, if you see the CRP trend has shown dramatic decline, which shows that there is possibly a role for the management of these disorders which are immune mediated. And probably for the other cases, just a thought that came to my mind is about the role of JAK inhibitors. If we can extrapolate that from the rheumatology world to the endocrinology, and to me, I think there is a Bennett study in the role of which is published in NEJM a year back. So again, because the diabetes mellitus in infants is a bit different, it's altogether different from what we classically see in adults, and it has a lot to do with immune-mediated insult, and probably that we can have a place of immunotherapy agent. Thank you so much.
Splice site variant.
Intron variant. Yes.
So splice site variant sometimes. Sometimes when there's splice site variants, the intronic variations also known to result in pathogenic manifestations. Even the engines, they are
So the probes that are used in next generation sequencing actually utilize these probes are directed not only against the exons but also exon intron boundaries, such that whenever there is any variation within plus minus 2 nucleotides of a particular exon, they are also captured, and these are important. Yes, sir. So the probes are designed just to target those.
I think NGS typically looks at the cDNA, not the mRNA. Would be able to detect. Especially it is typically at the level of that. Yes. Yes, sir, because like the TRMA case and the last case, it's syndromes. They both autosomal recessive biallelic mutations, so antenatal diagnosis is possible.